the opportunity. I will try and share my thoughts on controls in Taka's. So we have a 6-year-old girl who came to us with a congestive heart failure, hypertension, poor early function, and elevated biomarkers. And after doing echo and stabilization, we did angio when we found that she had a suprarenal severe coarctation, long deficit, so typical Takasu. So what do we do next? Should we stand, should we balloon, or should we just medical management? That is what we will try and discuss about this. So it's basically chronic relapsing remitting large vasculitis. Do you have a less inflammation? The more chronicity, long lesions are likely to develop. If you have more acute significant inflammation, there will likely to be have less chronicity and more likely to have acute aneurysm is likely to be there. So diagnosis is easy if suspected, but it's often delayed. We often see a large number of children with heart failure. Management is difficult and controversial. You can argue for and against both of them. It's a rare because of its a rare disease. There are no strong evidence available. Monitoring tools are not well established, and immunosuppressive therapy and procedures have significantly changed the outcome in these children and adults. It has a high long-term morbidity in the form of relapses, progressive disease course, and vascular complication. It has a reasonable mortality, and large number of our children present in our institute with a congestive heart failure. We rarely will see coronary ischemia, and there are post-op complications, and we rarely will see aneurysm ruptures are also noted in these patients. So we all know the natural history is quite not so good. The 12-year survival, if event-free, is about 84% if the disease is type 1. And on the other hand, if you have type 3 disease, then 12-year survival is only 29%. So if a child is active, has complication, there are chances of outcomes are actually quite poor compared to the child who is inactive and has less complication, is likely to have a good outcome. Among the major markers which determines outcome, what is that? Is it active? Is the complications? Is probably the most important parameter, along with severe hypertension and cardiac involvement, determines the long-term outcome in this such children. The major complications are which predicts are the retinopathy diagnosed on microaneurysm, severe aortic regurgitation, and severe hypertension will determine the long-term outcome in most of the patients with Taka's arteritis. The cornerstones of therapy is the immunosuppression therapy. Recently, all of you know that besides the steroid, methotrexate, and MMF, the biological drugs have been added to armamentarium of management, and they do help in managing such children. Revascularization procedure is a cornerstone in very selected patients. Both you can debate about whether you want to do surgery or percutaneously. Large number of these patients are able to undergo percutaneous intervention in the form of balloon angioplasty or stenting. And once you do that, you require to do antihypertensive platelets, and don't forget to control hypertension in such children. Aggressive immunotherapy is probably the cornerstones of these patients. Reduce activities within few weeks of starting therapy. A lot of people use tocilizumab. Our unit does not use tocilizumab in such aggressive. We tend to stick with the steroid, methotrexate, and MMF, and occasionally, very rarely, I have not seen my unit adding tocilizumab in such patients, but there are fairly good number of papers which describes the biological and tocilizumab therapy in such patients. A must before doing all procedure, we have to reduce, it helps in reducing the risk of dissection and reducing the risk of restenosis in such children and adults. The procedure is aimed to relieve the ischemia. The questions are, when should we do, what time you want to do, what do you want to do? And one must remember, when you subject the patient to procedure, there are fairly high chance of restenosis and acute thrombosis, aneurysm, and bleedings are available in this patient. Among the procedures, there are various available targets we need to talk about. Renal arteries, carotid, limb ischemia, or CCF is there. They all are helpful in such patient. What in this particular disease, like the thing, one must remember that not every stenosis need to open up. This is probably the most important. We should remember that this disease is not so good, and the results are not so good. So every stenosis does not require stenting or opening. That must be remembered in this. However, there are occasions where we come where, despite the child being active in activity or in CCF, Occasionally, rarely, you have to undergo such stenotic lesions there. So all procedure must be done in ideally in quiescent phase. Occasionally, you will have to do in active phase, but as a principle, do only when the activity is quiescent. Active is we avoid because high risk complication, arterial rupture, dissections of bone, and very high incidence of restenosis there in such patients. The therapy based on surgery or intervention in form of thing. In this meta-analysis of endovascular procedures of our surgery, they found that restenosis are very high in endovascular compared to surgical thing. However, strokes are more compared to surgical therapy in there. I think it depends on what is the lesion. You have to decide case to case basis. Very large number of children will undergo percutaneous intervention in such both children and adult. Surgery is preferred procedure if you are unable to use covered graft stent for aneurysm, and if the patient has severe aortic regurgitation, then surgery is probably the better option. There are no consensus for plus and against the surgery in such patient. Endovascular is a preferred and generally feasible in large number of children and adult for short and especially very good outcome in short and focal lesion, and patient is very high risk for open heart surgery. The advantage of balloon angioplasty is safe, efficacious, and very good lesion there. And unfortunately, the balloon angioplasty does not work in a patient who has a rigid or fibrous lesion is there. You make an attempt to dilate with a plain balloon angioplasty, doesn't work, then we have enough good hardware. We occasionally have only used twice cutting balloon in renal angioplasty, but you use cutting balloon, peripheral cutting balloon also is available. It works fairly well, and then you can expand with a normal balloon in such children. So angioplasty is fairly good, but it does not necessarily give you the good result. You may require cutting balloon in such patient. Stenting, unfortunately, has been used in this, but it's limited. It should be used with limited because a very high incidence of restenosis in children and periodontal thrombosis is there in such patients. Covered graft stents is generally reserved for the severe dissection rupture or aneurysm. Generally, is not in only two indication. If you have a large aneurysm or you have a rupture, and then I personally don't have an experience of using covered graft stent in Takayasu. In a study from Tyagi et al., he has predominantly used balloon angioplasty with very good result, and he has demonstrated in large experience that if the lesion length is less than 3 centimeter, then outcome is fairly good. If the lesion length is more than 3 centimeter, then recomplications are also fairly high. In his experience, the generally stenting is generally required if the patient has ostial lesion, a long segment, or patient has a lot of dissection, then he has used anything. In our unit, I have limited experience of 5 patients. I have used predominantly balloon angioplasty, and with fairly good result have been got away with renal angioplasty. Compared to the supraortic lesion, endovascular therapy is fairly required in children who has significant stenosis and patient is in the condition of heart failure are there. One of the common procedures we tend to get referral for subclavian artery stenosis is that most of if the patient does not have anything, even if the significant stenosis, one should not touch the patient and should be left alone. And it is best left alone with subclavian stenosis, and child will do fairly well with physiotherapy and exercise program. He will do well rather than doing your angioplasty. Coronary artery, if you document ischemia, you have to do intervention. I don't have any personal experience using coronary intervention in Takayasu. In meta-analysis, balloon angioplasty is fairly good, but the restenosis is very high, and stenting needs to be used effectively in selected patients, in only patient is there. Stenting is definitely better to achieve luminal loss, and lower incidence is there, but we have to use in patient dissection or passing restenosis or recurrent stenosis there. In stenting is generally preferred option in such patient. So what did we do with our child? He's been activity, CCF, severe early function. So despite the child was inactive, we could not, the unit was unable to control with 3 antibiotic drug and therapy. And hence, despite the activity, we had to use a long balloon angioplasty to relieve the obstruction. And you can see that after long balloon inflation, the results are not cosmetically good, but acute, the obstruction has been relieved, and we have left at this moment. We have not, despite the small dissection, we have not started stenting on this. The child was put on 3 steroid, methotrexate, MFF, and 3 antihypertensive. After you can see the angio child gradually over the long period, child has improved very well. And you can see the angio done after 1.5 years. After the initial angioplasty procedure, the fairly good amount of aorta has a remodel into it. So my message would be to avoid limited patients in stenting in such children. So to take home message in Takayasu arteritis, chronic vasculitis with high morbidity and mortality, no intervention should be done patient, especially in subclavian artery. Is there? It's not necessary you have to stent it. Aggressive immunotherapy is the key to the cornerstone of therapy. Even for your vascular intervention, you have to have aggressive immunotherapy. Survival benefit is definitely useful with vascular procedure only in severe disease in there. And whenever there is a stenosis, drug-resistant hypertension, you will have to go for a stenting. Or aneurysm is there, you have to go for stenting. Or severe aortic regression, you have to go for a surgery. We should avoid in acute phase. In chronic phase, we have to do intervention. Is there? I'd like to thank Dr. Anju Gupta, who is the professor of pediatric rheumatology, for managing the child and giving input in this slide. And team PCF, thank you very much.